thanks everyone for being here, and it's a great honor and a pleasure to be in this forum, representing Philips and representing my view as an imaging specialist within the cardiology domain. So it's really merging the two worlds and bringing to light a view of a level of expertise in terms of the imaging, and also the collaborations through industry, and how this crisis has even put us closer than before. So in this talk, I will address some of. I feel very fortunate that I'm talking after Dr. Lewis and Dr. Sugo, because we have already touched some of the points that I will address in a different manner. So we briefly mentioned the evolution of the disease and the different stages. And in this picture here, we can see the representation of the stages of the disease, as Dr. Lewis mentioned in her presentation, from the stage 1 to the stage 2, when there's stage 1 being more symptomatic, stage 2 having more of a pulmonary disease evidence or systematic disease. Sometimes it's not just a pulmonary affection, and the stage 3 when there's this host response and hyperinflammation. And then the fourth stage, which is there any chronic disease going from COVID, and what do we know about it? And the importance of the stages of the disease is that it really relates with the value of imaging in each one of them, and that's what I'm going to address going next. So when we think about the diagnosis of COVID, this has been really a challenge for I would say for the medical field, but also for the industry, to really understand how are we diagnosing COVID and what can we do better. Because if we think about the traditional clinical pathway, the patient gets symptoms and then has an RNA test. And we know that on average, still now, up to 20% of those tests can be false negatives. So we are seeing a diversity of approaches across the globe. And has a device company and looking into different ways of dealing with the disease, it's a challenge. So simultaneously to optimize our tools to provide the best diagnosis and to keep up with the novelty that keeps on coming from the advances of our learning. And we have learned, especially from China, that has been having a different approach compared to the rest of the world on the use of imaging modalities to diagnose, especially the use of chest CT. So we know about X-ray, that there are data that show X-ray with abnormalities before patients actually had even evident symptoms that we would expect for the abnormalities on the X-ray. But particularly chest CT and ultrasound have been the focus of our attention for diagnosis. And I brought to your attention these two studies. And one comes from China, the other one comes from Wuhan. Also, these two are from China, but there are also studies from Italy. Sorry for the misgap here. And in one of those, the one represented on the left, it's more than 1,000 patients that were evaluated using chest CT at the time of that they recurred to hospital. And among those, if you see here on the division at the bottom, the green represents when there was an agreement between the CT and between the PCR for SARS. There's about the representation in this study about 300 patients that have a negative PCR and a positive CT, and that when we see the other way around, there were 21 patients with positive PCR that were missed on CT. And so this led to the reflection: what's the value of these imaging modalities for diagnosis? And although we recognize the challenges of posing them at the forefront for diagnosis and the risk of the healthcare professionals' exposure and the risk of the exposures within the overall hospital, we also have to reflect on the current circumstances, what is best to offer to also minimize the lost infections. And here it's an example of a symptomatic patient. So even asymptomatic patients present with abnormalities on the CT. And this study looks also to, this is a meta-analysis that looks to the value of the CT for the diagnosis, and not surprisingly, from what we learn as of now, it's very sensitive, but very with low specificity, because although we see the abnormalities, it's not specific for the virus, although there's the description of traditional signs. And this leads also to those challenges that join again industry and academia, which is looking to how to optimize this, because how can we do better without having to have this learning curve, and without having to be experts of having to have experts available across the globe to interpret these images. And so here it comes the value of the artificial intelligence, and that is being developed not just for CT. CT are another imaging modalities, for ultrasound as well, which I will talk in a minute. But to add the value of the understanding of this on the top of the understanding of an expert. And in this study, it's very interesting to see that they achieved an ROC curve of 0.92 by doing this AI model in this setting, alongside and added up with the clinical data. And Dr. Lewis talked about point of care ultrasound, and point of care ultrasound has multiple uses across the disease, but it starts at the diagnosis. And this actually we heard much more from the experience in Italy. And in Italy, we started to receive data and information. So physicians from at the forefront coming to us and telling, you know what, you have to help us to bring this word out, because we are seeing these abnormalities in lung ultrasound, even in patients that are having a negative test. So how can we deal with this? And these are examples of studies of abnormalities in lung ultrasound in patients with a negative swab. And there's already recommendations put by some researchers that once having a negative PCR, to consider to do a lung ultrasound before really having the understanding that the patient is definitely negative, especially when there's clinical suspicion. And beyond that, after the diagnosis, how does this imaging modality can impact on management? So there's the ones that are able to actually implement in clinical practice have been finding that adding that up with clinical data, especially on the need on the oxygen supply, can help to determine where the patient should go. So from home to in ward to even ICU. So, and this is a courtesy from a friend, I'm sure known from a lot of you, from Dr. Luna Gargani from Italy. And I find it fascinating because it puts the lung ultrasound across a CT of a patient and abnormalities that are found and that match what is found with the CT. So we're still lacking more data on the comparison between these two modalities, but it's very interesting to see on the match. This is the same patient a few days later, and we can see actually the unfortunate negative evolution on it, but it's very representative of the images. And when we go along with this and we look to the value of point of care, we have been seeing this ramping up across the globe for lung ultrasound and for cardiac for sure. So we have that it's something that has physicians, we recognize that adds value when a patient comes through the door at the emergency room with shortness of breath or with a clinical that we need more data. And in this context has been really the ideal tool, because this is the example of a colleague of ours using point of care with all the personal equipment. So it's really by the bedside, and provides information not just for the lungs but for the heart, and if in a skill person that is doing the ultrasound can even go beyond and help in the access of catheters and other aspects that we know that ultrasound can give value on. And I will skip this one because we mentioned this early on the effects of cardiovascular system, and I'll speak a little bit more on the value of the image, on actually the complications on the cardiovascular symptoms, the cardiovascular manifestations on COVID, and among those, one that I find particularly fascinating is the examples that Dr. Lewis also brought up on the patients that come in the emergency room that before COVID we would be rushing to send to the cath lab and assume has an acute MI, and now we are seeing that they arrive to the cath lab and the coronary arteries actually have no obstruction. So that has brought up to light the value of doing imaging before going to the cath lab, and that imaging again can be point of care ultrasound, but also allow the expansion of CT and thinking about CT in certain cases on that the suspicion is significant to not activate the cath lab and all the protective equipment that has to go along with it. before there's a significant reliance on the need to do so. So this is expanding our vision to consider CT for coronary artery assessment in the emergency room, and this comes along in the recommendations from the Cardiovascular Computed Tomography Society, and also from the European Society of Cardiology guidance for the management of these patients. So that's something to consider as well. When we look at the value of the echo in across the population of COVID patients, and when we touch upon this briefly, the right ventricle dilatation is actually what comes across as the most frequent pattern, and that most likely has to do with the prothrombotic stage, and also from there we can also see that although almost 40% of patients in this systematic review of 100 consecutive patients has RV dilatation, there's a normal echo in 30% of the cases. Then there we can expect the other abnormalities of left ventricle dysfunction, and also attention to left ventricle diastolic dysfunction. So that's something that has been coming across as somehow frequent. And this is interesting how it came across in the news as so significant, and in terms of the right ventricle value, and how does that relate with prognosis? So this study found that as a predictor of mortality of these patients. So that it's one of the data that we have that we can consider in patients coming across, and that can help to triage the management and to adjust to it. And while thinking about that and thinking about the value of echo and how to evaluate the heart and what's the prognosis for the future, we also look for data of other imaging modalities. And obviously, there's not much on MR. For obvious reasons of the risk of cross-contamination. But there's I would like to call your attention for this study that in these 26 recovered patients underwent MR, and I think it's also a time for us to reflect what should we expect from these patients that will recover, that we are starting to see, and in most of the cases these patients, so there was an abnormal MR, mostly with edema, but also with signs of fibrosis in a significant percentage of the patients. So that also brings us to questions: what should be the imaging and the clinical follow-up of these patients, and what can we do better and continue to improve in terms of industry and clinical collaborations to help this to be more standardized across the globe and to provide better patient care. So in summary, my main takeaways is that we have to reflect that in the context of a pandemic, an imaging approach can help to identify patients with COVID, with the focus of avoiding further spreading of the infection. That AI is coming up as a tool to help to diagnose using different modalities for the close future. And transthoracic echo and coronary CTA so have an important role in the diagnosis of cardiac complications and can help also to triage patients for further management. And the cardiac consequences of the patient successfully recovered from COVID are very largely unknown. So with this, I would like also to call your attention for a lot of papers and statements from the different societies that can help us to guide on the use of imaging and to think about how to improve going forward. And I'm very happy for the discussion, and I would like to thank for your attention.
Thank you, Alexandra. Excellent and brilliant talk. I think that there are many questions related to the possible interaction of the different multimodality technologies to early detect. So we have here a question from Madalena Letino from Italy. And Alexandra, do you know whether are ongoing retrospective trials aiming at matching different imaging techniques with the clinical profile of COVID patients to build up a diagnostic algorithm that may be used, as you said in your conclusion, routinely in overcome false negative tests?
Yes, so to my knowledge, there are is in two examples, mostly dedicated to lung ultrasound, but using CT and using lung ultrasound. So both of these two different databases are being looked at for development of tools to help to diagnose using automation. In terms of the cardiac assessment, those are also being constructed, but not as advanced as the lung ultrasound or lung CT, to my knowledge.
Yeah, and also how you envision the early detection with imaging of the carriers, asymptomatic carriers.
Yeah, so that's a great question. So there's two components to it. Though there's the component of the lung assessment, which seems to be incredibly prevalent and surprisingly occurring in asymptomatic patients. Then there's also studies on assessing the heart with more advanced techniques, like we know as of strain, using strain for the right ventricle and the left ventricle, and having trying to understand if those are early signs of affection of cardiovascular disease, but we still are up to learn what do they actually mean for asymptomatic patients.
Here's a question related to the right ventricle, and is there a correlation between the right ventricular dysfunction that we see in echo, and you mentioned now with a strain, for example, and the severity of the lung disease?
In some cases, yes, but it's not consistent. So, I would love to hear Dr. Lewis' experience on that as well, because what comes to us and what I had opportunity to revise, there's not absolute concordance on that. So we can see sometimes patients that doesn't seem to have so severe pulmonary disease, but in consequence of a thromboembolic event, suddenly have the right ventricle dysfunction, and that can be fatal and even explain some of the sudden deaths in younger population. But I would love to expand the conversation to Dr. Lewis.
Yeah, I wish I had something to add. I think you covered it. It's normally it would that arterial vasoconstriction due to hypoxia would cause the RV to fail, and we would see that typically in pneumonia. But I think there are other factors, including the direct viral insult to the RV, the direct cytokine insult to the RV, some systemic effects as well. So nothing.
And in this sense, a personal question there: do we see inflammation in the right ventricle in early MR studies?
If we see inflammation in the
right ventricle,
in the right ventricle in the magnetic resonance imaging studies, is that the question? Yes, there's what I have seen. It's really small data. So our studies there are studies of one patient report that presents inflammation in the overall heart, left ventricle and right ventricle. In terms of the more comprehensive cohorts with at least more than 10 patients, and that's the number that we are talking about, there's the frequent presence of edema in the different stages. So being edema and the reference point for inflammation.
Another question here, Alexandra. How do you see cardiovascular imaging evolving as a health system open up with a decrease in COVID prevalence?
So the health system involving for overall of our patients, right?
Yeah.
So that's what I'm taking the question. Yeah, so I'm honestly concerned on how our patients overall and not just the COVID patients might be lagging behind the continuity of care. So what we are partnering with and what we are approaching to do is to help overall health systems to be better prepared on providing the image with safety, and that can have different meanings. Can have more the meaning of portability, the meaning of having faster and faster ways of acquiring the image. So it allows time for cleaning, allows time for the personal protection equipment, time for preparation, and also in terms of automation and standardization for the reading, so that we can have patients not have to come just to centers of excellence, but have proper care, even if they are in a more remote area. So we see the evolution on coming closer to the patient, and that is something that patients deserve, and that's something that is a trend that we can reflect on from the past. But COVID is accelerating, and if there's positive things that we can take from this pandemic, that can be one of them. So we are seeing the advantages of telemedicine, but also in terms of what all relates with imaging, the acceleration of automation and the opportunity of standardization and bringing closer to remote areas the quality of having access there, and also remote access to experts that can be even in other countries.
And we have a last question, quite brief, Alexandra, please. And this is coming from the Netherlands. I mean, no doubt that COVID is, there is no frontiers for the COVID infection and the COVID problem. And if we extrapolate that to the artificial intelligence algorithm that you talk about, only for imaging, which additional patient information, such as lab, ECG, other information, clinical information, will be good for your algorithm?
That's a great question, and certainly when the stronger the result will be, the better information will be feeding for the algorithms, right? And from, I think, from first days of medical school, we learned that's not unique data for individuals, right? And more complex being the disease, more data will need to have to make it useful. So the clinical data anticipated being of great importance, and being that clinical data, since demographics, to more details in terms of how patient is needing oxygen, the blood sample results. So we can go into different steps to this, and we can triage what actually will be more important. But I can highlight that the main importance will be having good quality of data. So that's something that we always fight for, even coming from imaging or coming from labs or coming from clinical assessment. But the way I see it will be the imaging collected with the clinical assessment to make it strong.
Okay, thank you, Alexandra.